Good afternoon, everyone. Welcome to our live webinar, Understanding the Brain to Treat Depression, as part of Mental Health Week. My name is Dr. James Casby. I'm a postdoctoral researcher here at QBI, and I'll be your MC today. While my research tends to focus on psychosis, as with many of these mental disorders, we often find that depression is a co-occurring problem. So I think it's really important that we understand the underlying mechanisms involved with depression. So, firstly, I'd like to acknowledge the traditional custodians and owners of the lands on which we meet today. I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. So before we get started, I have a few housekeeping items. On the webcast player, you'll notice a speech bubble. If you have any questions or comments throughout the webinar, please fill the form and click send. If you require technical support, please click on the I, where you'll find a link to access live chat support. Most importantly, this webinar will be available after as a recording, so if you miss anything or have any troubles today, you can still watch it afterwards. For those of you not familiar with the Queensland Brain Institute, we're an institute with 400 staff, and we focus on all sorts of things. We've been around for 17 years, and basically every researcher here is looking to understand the organisation, development and function of the brain, and especially when those things become dysfunctional and cause some of these problems we have today. So today's webinar is on depression. And I think depression is a mental illness that we can all relate to in some way. We often get sad. We've all had those moments where we're not motivated to get out and do something, especially this year. But on the same note, while that's positive to reduce the stigma of the disorder, I think sometimes it can be counterproductive. People with severe depression and major depression have problems that we can't relate to. And I think that's part of the problem with why sometimes that can be counterproductive. And I think you'll hear today that when you have some of these severe disorders, they can be insidious and debilitating. But thankfully, we have some of the world's experts in depression research with us here today. We'll first hear from Dr. Dhanisha Jhaveri and Dr. Susannah Tye, who are using preclinical and translational approaches to understand what goes on in the brain during depression. Then we'll hear from Dr. Phil Mossley, a psychiatrist who specialises in deep brain stimulation approaches. We're going to hear from each speaker, and then I'll ask them each a question. That's one of the perks of being the MC. And then we'll open up for the discussion at the end. So without further ado, I'd like to introduce Dr. Dhanisha Jhaveri. Dr. Jhaveri has a joint appointment as a group leader here at QBI and at MARTA Research. Her preclinical research focuses on understanding the brain's neuroplasticity mechanism relating to generating new neurons and how to harness this to improve outcomes for those with depression. Thank you.
Thank you, James. So as James alluded, depression is one of the most complex and heterogeneous disorder affecting millions and having an enormous socioeconomic and individual consequences. Selective serotonin reuptake inhibitors like Prozac, which have been used for over past 30 years, have had a really good effect in some individuals, but in many, up to 2/3 of them, either they are only partially effective or in fact ineffective. Now this has led to treatment resistance, increased rates of relapse, and also multitudes of side effects, which are all now contributing to being one of the leading causes of disability, depression being one of the leading causes of disability by 2030. Our efforts into developing new antidepressant treatment drugs have met with a lot of challenges, in part because we really still do not understand completely the pathophysiology of depression and how really some of these antidepressants work in our brain. However, what has become really clear from large efforts in research over the past several decades is the interaction between genetic factors and environmental factors that both play a very important role in precipitating in depression. What has become quite important is like environmental factors, especially those related to stressful events, early life stress, for example, or traumatic events, are major risk factors in developing depression. And these genetic and environmental risk factors have major impact and interact at the level of affecting the brain plasticity mechanisms. And that really underpins whether a person is susceptible, for example, that they go on to develop depression, or they are much more resilient and they don't develop depression. So understanding how these genetic and environmental factors interact and how they impact these neuroplasticity mechanisms have become a major goal in this neuropsychiatric disorder. Now let's again consider that this is really a real condition. Depression is a real condition, just like diabetes or cancer. It's not just something of a mental state that you can get over with. There are structural and functional changes in the brain that are occurring in these patients. While there are multitude of brain regions impacted in these disorders, one of my favorite one, the hippocampus, is one of the central node there. Now hippocampus, if you have a damage to this region, which sits in your temporal lobe and is a seahorse-shaped structure, it actually affects your learning capabilities and mood regulation. Now what is being shown, in fact, is in patients suffering from depression, there is a significant reduction in the volume of this structure, the hippocampus. And this atrophy, hippocampal atrophy, is correlated with the depression severity, as you can see on the right-hand side, the red being where the atrophied area in the hippocampus. So it's needless to say that such a complex disorder will have a very complex and multifactorial mechanisms implicated. And again, research over the last few decades have uncovered multitudes of these mechanisms involving, for example, changes or chemical imbalance in the brain, changes in how we respond to stress, for example, the changes in the stress axis, even things related to inflammation. What is really important here is that many of these findings have come from using well-defined animal models. These animal models have been crucial in providing some of the insights into how these different factors, such as neurotransmitters or chemicals that I just spoke about, or stress, really alters the structure and function of the brain. And the reason that we can do that is, especially, for example, those related to the stress and how stress impacts the axis which regulates the stress response, is actually evolutionarily conserved across organisms, including in mouse and human. So the way the human or a mouse responds to a stressful situation and the cascade of events that happen following that are actually similar. Therefore, I think one of the central tenet from these studies have led to the idea that these structural and functional changes in defined neural circuits actually underpin some of the symptoms or the core features that are associated with depression, such as anhedonia, such as low mood, such as those related to anxiety or decision making or reward. And hence, these circuit-based mechanisms have become one of the important areas of investigation in recent years. And one such circuit-based mechanism which involves neuroplasticity is generation of new neurons, a focus of my research program. So adult neurogenesis is a process by which neurons are generated in the adult brain. There was a dogma that existed much of the last century that our brains are immutable and new nerve cells cannot be generated. However, there is now sufficient and considerable evidence showing that this form of neuroplasticity mechanism actually occurs in the adult brain, including in the human. We actually have resident population of neural stem cells residing in the brain, and in this case, I'll show you a picture that shows in red these stem cells residing in the hippocampus, my favorite structure, in the mouse brain. And these stem cells, upon the correct stimulation, can lead to actually activation and generation of new neurons. And these new neurons are believed to actually rejuvenate the circuit that they are growing in, so as to contribute and impact functions such as learning and mood. Interestingly, this generation of new neurons is very sensitive to various environmental factors such as physical exercise, antidepressants, and environmental enrichment. And they are negatively impacted, this process, by stress, aging, and inflammation. So you can see already here that stress and antidepressants, two of the major things in understanding the biology of depression and the treatment, are actually having a huge impact on this neuroplasticity mechanism. And this has led to the hypothesis in the field and the theory that impaired neurogenesis due to chronic stress actually leads to some aspects of mood dysregulation. And antidepressants, on the other hand, which increase or restore neurogenesis, are partially responsible. This process is partially responsible for the beneficial effects of antidepressants. However, how precisely these stress and antidepressant impact these population of new neurons and regulate genetic expression, their connectivity within the circuit, and their functional activity are some of the questions which are still unanswered. And this is what my research program is focused on answering in our lab. So in the lab, we actually interrogate this at multiple levels, encompassing things looking at the cellular mechanisms, how really stress affects the production and the integration of these new neurons, what are the behavioral consequences of these in animals, where we can read out some of the core symptoms of depression, such as anxiety or anhedonia. And on a broader scale, we're trying to interrogate how it affects really the brain-wide connection and the activity. So for example, I've just given one snippet of some of the work that we do, where we have developed an animal model of depression, where we can show that prolonged stress over a period of 1 month leads to anxiety-like behavior in animals, shown here in increased latency to eat in an orange bar. But if these animals are treated concomitantly with antidepressants, you can prevent these anxiety-like phenotype. And this provides us as an inroad and as a mechanism where we can exploit how really antidepressants are working at a cellular level. And this has already led to our understanding that these new neurons are critical for mediating both the response to stress and the effects of antidepressants, whereby they may be affecting select biology of these neurons, for example, in this case, how they really develop. And this has given us ways and insights into perhaps harnessing this mechanism to either prevent or treat depression. So to conclude, I think psychiatry is really in an exciting phase of discovery at the moment, and with new mechanisms that are being uncovered, both genetic and the circuit-based mechanisms which are involved in regulation of mood, we are certainly on the path to come up with and discover new ways to treat this disorder.
Thanks, Dhanisha. So you've shown some interesting things with stress and antidepressants. How do you think this, as a translational animal model, how do you think it's going to help human applications in the future?
Thanks, James, for that. This is a really important question because, as you're aware, many of our studies which are looking at the cause and effect relationship in animals and which show importance of certain cellular mechanisms and circuit mechanisms, how they really, how we can actually translate into humans is sort of the next era. And I think the important things to consider here are both the scale and the resolution of our understanding of the brain. While in animals, with modern neuroscience tools, where we can visualize and manipulate very selective population of neurons and subpopulations of neurons in defined circuits to interrogate how they impact behavior, these are really not yet open to they're not open to our understanding in the human brain. So we have to have certain modalities or technologies that bridge this gap. And some of the recent advances that have been made in making neural recordings, so using very high recording devices to actually peer into the neuronal activity in the brain-wide manner, along with probably magnetic resonance imaging analysis and capabilities that we have, probably will be a very useful way forward in combining and bridging this divide.
Oh, excellent. Thank you very much. So our next speaker is Dr. Sue Tye. Dr. Tye is a group leader here at QBI. Her work uses clinical and preclinical approaches to understand how antidepressant treatments reverse the effects of stress, what biological factors block these effects, and how we can use biomarkers to help predict what treatments may be the most effective in people with depression. Thank you, Sue.
Thank you. So my research, I think, complements Dhanisha's very nicely. Dhanisha has done so much work to explore how depression or how stress changes the brain to induce depression-like behaviours, and what are the underlying neurobiological mechanisms associated with that. My work looks now at how can we reverse that, how can we repair the brain following exposure to chronic stress or traumatic stress. And first I just want to highlight that depression is so much more even than the brain and psychiatric symptoms in terms of the emotional symptoms that we so often associate with depression, feelings of low mood or anxiety or tearfulness. There's a whole host of physical symptoms that occur with depression that indicate it goes much deeper than that, and actually it's a whole body disorder. It affects energy, it affects sleep, it affects aches and just a sort of general function throughout both the body and the brain. And this we found is really important for actually how the brain responds to antidepressants. And antidepressants, when I first started in this area, I assumed that they worked for everybody. That if you took a serotonin reuptake inhibitor, you'd increase levels of serotonin in the brain, and that would replace the serotonin deficit that was popular at the time to be a cause of depression. We know now from studying how people respond to antidepressants that that's not the case. It's not a matter of taking an antidepressant and getting better. Only about 37% of patients that seek help through antidepressant therapy will receive a therapeutic benefit from their first treatment trial of an antidepressant. And those that don't respond go on to try another treatment, and over a sequential trial and error of different antidepressants, we find that there's still a subgroup of individuals that aren't responding to any of the available antidepressant treatments out there. And we're really interested to find out what are the reasons that some people don't respond. And as Dhanisha nicely pointed out, part of what antidepressants are doing are helping the brain repair the damages incurred by stress. And antidepressants are far more than just antidepressant in the sense that they reverse that negative mood. They're actually blocking or reversing the harmful effects of stress on the brain. And we know they do that through mechanisms that promote neuroprotection, neuroplasticity, and neurogenesis. And they do that via stimulating molecular machinery within the cells that facilitates neurotrophic or growth factor signaling, essentially signals that promote the growth and repair of the connections between brain cells. One thing that we've discovered is that what is essential and what has been overlooked for quite a period, because we've been so focused on trying to understand the effects of stress on the brain, is actually that there are limiting factors that prevent this response from occurring. If the brain can't make use of energy effectively or doesn't have the available nutrients to undertake this repair process, then antidepressants are limited in their capacity to rebuild the brain and repair those damaging effects of stress. So our work has really tried to zero in on these mechanisms. And we've found that just by exposing an animal to chronic stress hormone, so adrenocorticotropic hormone is a hormone that stimulates the stress response. It's a very natural process. It happens in all of us every day just to facilitate daily biorhythms. When that occurs or that rhythm becomes dysregulated, it has effects that trickle on to metabolic systems and inflammatory systems, and we think this contributes to some of the physiologic consequences or side effects that are seen in depression, symptoms that are seen in depression. What's illustrated here are some of the molecular pathways involved in rebuilding the connections between brain cells. And we've known for a long time that antidepressants stimulate those growth processes, and that response is associated with the time course of recovery. So the serotonergic based treatments can take weeks to months to be effective, and it takes those weeks to months for the cells to adapt to facilitate these growth processes. The newer treatments, such as rapid-acting antidepressants, where these therapeutic effects can be seen over the course of hours to days and occur very rapidly, they also stimulate this cellular machinery very rapidly. And using these particular rapid-acting antidepressants, we've been able to study the effects of dysregulating the stress hormone axis and impairing mitochondrial function and promoting inflammation on blocking these particular pathways. And as Dhanisha said, using animal models has been so important for this because we've not only been able to study it in the brains of these animals, but show that we can actually measure these changes in their peripheral blood, which has led us on to thinking about how can we identify some of these changes in the blood of patients. How can we potentially know in advance if somebody is likely to respond to first-line antidepressant therapy, and how can we potentially take that and use it as a predictive biomarker. And one of the key molecules in the body that is regulating this neurotrophic growth response and also coordinating energy metabolism is insulin. And we've been able to see that ketamine is rapidly regulating the release of insulin in the brain and the body. Ketamine is very interesting because patients will respond to it very quickly, or they won't respond at all. And in a clinical trial, we identified that approximately half of the individuals that were receiving ketamine responded very rapidly, and by their second treatment, they had received a very robust change in mood. The other half of the group didn't respond. Building on what we had seen from our animal studies and the way that the brain was responding to ketamine to promote the antidepressant response, we wanted to look if we could see that at the level of a peripheral blood cell. So we took those blood cells from the patients, and we were able to stimulate them with insulin and look at activation of these pathways. And we've seen repeatedly now that there's a very rapid differentiation between the remitters, the patients that receive that therapeutic benefit, and the non-remitters at the level of the at white blood cell. And our next step is really to try to develop new ways to target this treatment, to target these mechanisms so that we can promote that antidepressant response more effectively, to facilitate that metabolic machinery and enable the brain to respond as effectively as possible to antidepressants. Thank you.
Thanks, Sue. So you mentioned earlier in your talk about everyone is different with regards to what leads to all their symptoms of depression. So if the Holy Grail is precision medicine, personalised medicine to each individual, how do you see the relationship between sort of broad treatments versus precision and personalised medicine in the near future before we reach that end goal, Holy Grail?
Yeah, I think it's starting to really appreciate that a disorder like depression is heterogeneous, and really looking at the individual. There are currently a whole host of different antidepressant treatments available, and even just taking the time to talk through the different symptom profiles that different patients might have can provide insight into what might be the best approach for each individual. And augmenting the pharmaceutical therapies with behavioural interventions and regulating sleep patterns and optimising diet and all of these other factors can be incredibly helpful. But I think what we can do now is really take the individual and look a little bit more closely at the expression of those symptoms to see, what is the right treatment for that individual versus this is the first treatment we always offer, and you should try that.
Fantastic. Okay, so our final speaker is Dr. Phil Mossley. Dr. Mosley is a psychiatrist and fellow at QBI and QIMR Berghofer Medical Research Institute. His work is looking at how deep brain stimulation can improve symptoms across multiple disorders. Thanks, Phil.
Thanks, James. I thought I'd just give a little bit of an insight into the research I do, although, of course, I'm very happy to answer any questions from a clinical perspective about the treatment of depression as a psychiatrist. So one of the cool things that I do is I'm part of a clinical team using deep brain stimulation to treat movement disorders and increasingly treatment-resistant psychiatric conditions. Deep brain stimulation is a minimally invasive form of targeted brain manipulation. In a neurosurgical procedure, 2 or more electrodes are inserted into the brain under very precise guidance using neuroimaging and electrophysiological recordings. In Parkinson's disease, the typical target for the electrode implantation is a region of the brain called the subthalamic nucleus, which is deep within the brain about the size of an almond. 1 electrode is implanted per hemisphere. And the team that do that in Brisbane are led by Professor Peter Silburn and Assistant Professor Terry Coyne, and I'm the psychiatrist in the team there. The team in Brisbane have been operating for over 15 years and are one of the most experienced teams worldwide in the application of this therapy, having implanted over 1,100 cases of people with movement disorders. So they really are groundbreaking leaders in their field, and I'm very lucky to be a part of that team. The reason why a psychiatrist is involved in the treatment of movement disorders is, well, twofold. Firstly, movement disorders such as Parkinson's disease have a very strong non-motor element of comorbidity, so things like depression are very prevalent in people with Parkinson's disease. Up to 50% of people with Parkinson's disease will suffer with depression during the course of their illness. Secondly, one of the unintended side effects of electrical stimulation within this particular target is mood changes and changes in behaviour. And one of the unintended benefits of that, in turn, is our ability, as both Dhanisha and Sue have mentioned, to enable circuit-based interrogation of specific symptom profiles and behaviours in the human brain in these individuals who have been implanted with deep brain stimulating electrodes, and that's really what my research has focused on. So one of the things that we can do with these individuals is look at exactly where their electrodes have been implanted, and using the neuroimaging that we've acquired as part of their surgical workflow, simulate which regions of the brain are being stimulated with electricity. And then we can map that using structural or functional connectivity to specific brain networks, brain circuits that are activated, if you will, with this pattern of focused electrical stimulation. And we can map that to behavioural changes in our patients. And in people with Parkinson's disease, one of the most common side effects of deep brain stimulation is actually the reverse of depression. It's mood elevation, harmful mood elevation, which we term mania. Now, this is relevant here because it gives us an insight into which circuits in the brain can increase mood in individuals with treatment-resistant depression, for example. So it gives us that ability to be almost transdiagnostic in our studies, looking at one disorder, what pattern of brain network activity is associated with mood elevation. Can we then apply it to people who don't have Parkinson's but have treatment-resistant depression to change their pattern of brain network activation to treat their intractable disorder? One of the powerful things that we've done in our research is team our brain imaging with some behavioural assays which are more sensitive to changes in symptom profiles. So one of the challenges in psychiatry is a lot of our assessments are based on quite lengthy and detailed mental state assessments or symptom checklists which take a long time to administer and aren't particularly sensitive. What we've been developing are more sensitive behavioural assays to tap into real-world type of behaviour. And in our Parkinson's patients, we designed a casino for them to play in to capture some of this impulsive and risk-taking behaviour that some of them exemplify following the deep brain stimulation. And using this information, we were able to identify specific brain circuits that were implicated in these psychiatric changes, unwanted psychiatric changes in our participants, in our patients who've had subthalamic DBS. One of the other studies that I've been involved with through my role in the deep brain stimulation team is treating intractable psychiatric conditions with DBS. And we've just completed a trial of deep brain stimulation for treatment refractory obsessive compulsive disorder. And again, that's a different disorder to depression. People with obsessive compulsive disorder have very intrusive and unwanted thoughts that are their own thoughts. They're not psychotic in nature, but they're typically associated with things such as contamination, harm, threat, unwanted sexual thoughts, blasphemous thoughts. And people with OCD often have ritualistic behaviours that they engage in to mitigate the anxiety that those thoughts engender. Like depression, the first-line treatment is antidepressants, and like depression, many people with OCD don't respond to treatment with antidepressants. And we took a group of people with lifelong refractory obsessive compulsive disorder and stimulated in a region of the brain called the bed nucleus of the stria terminalis. And again, using DBS, we were able to interrogate the brain and find out exactly which circuits were implicated in recovery from their previously debilitating psychiatric disorder. Interestingly, we found that circuits involving the hippocampus, the amygdala, and the fornix, a circuit that's known as the circuit of Papez, was implicated in people recovering from OCD after deep brain stimulation. So again, that gives us an opportunity in the future to increasingly, for this disorder, personalise this treatment to make sure that we are targeting that circuit implicated in fear conditioning and habitual behaviour with our electrical stimulation, with our focused electrical stimulation. And applied to depression, it also gives further credence to the sense that really we should be trying to, for these people with very severe treatment-resistant depression in whom we're considering deep brain stimulation, we should be really trying to personalise the treatment based on brain network architecture and symptom profile to try and stimulate regions of the brain that are implicated in treatment non-response. Okay, thank you.
Thanks, Phil. So obviously deep brain stimulation is kind of limited to the very severe mental illnesses that can't be treated with any other form. Mm-hmm. Do you see anything in the future technological-wise or anything else that might be used with a broader suite of people that maybe doesn't require surgery but does the same idealistic thing that you're doing with the deep brain stimulation?
Yeah, well, transcranial magnetic stimulation is the obvious candidate there. So that's a non-invasive form of neuromodulation where a magnetic coil is applied to the scalp and using strong magnets that induces a change in electrical activity in a specific region of the brain. And interestingly, recent research, including research from Australia, has shown that treatment response is really defined by picking up those brain networks that are implicated in DBS response in depression. The The benefits of TMS are that it's non-invasive, of course. The drawbacks of TMS is it's not as powerful treatment as deep brain stimulation, obviously. It requires lots of sessions, so you have to have a session a day, preferably 5 days a week for a month to get a treatment response. And then you have to have repeated sessions because it's not a continuing treatment. However, for many Australians with mild to moderate symptoms of depression, it's a much more acceptable form of therapy and would be is being increasingly used in Australia.
Oh, fantastic. Okay, thanks for that, everyone. So I'd like to open up for questions and comments now. So if you click on the speech bubble below me, I'm told, you can please provide your name and email address, just in case we don't get to your question today. We also have some staff from QBI here in the audience. For everyone in the room, please wait till you get the microphone to speak so that people on the web can hear your questions. So do you see a place for ketamine long-term in the treatment of depression, specifically neural plasticity? Who wants to open that one? Sue?
So yeah, I think definitely ketamine has been a paradigm changer for the field of antidepressant therapeutics. And I think the goal is really looking at how can we take what we've learnt from ketamine and develop something that has lower risk for patients longer term. And so I think it has done amazing things and it's very helpful for a lot of people. But even if ketamine remains something that's used continuously, are there ways that we can augment it and lower doses so there's less risk of some of the negative effects of ketamine?
Oh, excellent. What is the differences between antidepressants and anxiolytic drugs? Do they work differently on the brain? When is not okay to take them?
I'm going to take that one. This is a conversation I often have with my patients. They say, when I'm treating them for other conditions such as depression with an antidepressant, they say, "But doctor, I'm not depressed. Why are you prescribing me an antidepressant?" And I have to say to them, well, they're called antidepressants because in Western society we just love classifying things and lumping things into categories. And what we do with these medications is we alter the physiology and functioning of the brain. And we can do that for various conditions, including depression, anxiety. I use antidepressants to augment executive functioning in people with brain injury and Parkinson's disease. Antidepressants can be used for neuropathic pain. There's a post-traumatic stress disorder. There's a broad range of functioning, broad range of conditions where antidepressants can be used. Anxiety is a condition where antidepressants are also very effective. Different types of anxiety, I won't get into it. So you can talk about an antidepressant also being an anxiolytic. Anxiolytic meaning relief or reduction of anxiety. There's another group of medications called benzodiazepines, which have a very different pharmacology, work on the GABA system in the brain, and are much more crude, if you will. They're sedating. They do help. They do have a role in psychiatry and in medicine. They can be used to help sleep. They can be used as an acute treatment for anxiety. They can be used during alcohol withdrawal. They can be used as muscle relaxants. The thing about benzodiazepines is that they do have a capacity to show tolerance and dependence. So over time you need higher doses of the drug to get the same effect. And if you don't get the drug, you get withdrawal symptoms. So we tend to try and use them very sparingly in medicine, but they do have a role.
Oh, excellent response. Very detailed, thank you. So we hear a lot about early detection. Do you think there's any way, and I think we can go through the panel members here, do you think there's any way we can prevent depression, and what is the risks associated with trying to go down that path?
I can answer that. That is a very important, again, a question. And I think, again, the animal models here are going to be quite powerful, and combining animal models with the modern neuroscience tools, such as, again, visualizing and manipulating selective neuronal subpopulation within a circuit, will provide us with ways to understand how these circuits regulate, as Phil was talking about, certain symptoms or features that are associated with anxiety depression kind of behavior. For example, fear and anxiety, reward circuits, decision making. So this, combined with some of the understanding of how stress affects some of the early events in changing these neural circuits, how it impacts gene expression within these neuronal subpopulation, and what effect does it have at the epigenetic levels, will start to provide us probably some insights where we can use those to think about ways and strategies to intervene at an earlier stage to prevent that progression into a later stage.
Do you think we could use blood markers to detect who's at risk?
Yeah, I think we can certainly detect a number of factors in the blood that might indicate somebody's maybe hyper-reactive to stresses or particular stimuli. The better we understand the cellular consequences of chronic exposure to stress, the earlier we can intervene. So we do see accelerated aging at the cellular level. But I think it's important to also remember that a lot of, particularly what we've learned from animal models, is that stress has a significant effect on risk for depression. It doesn't affect everybody in the same way, and there are a number of factors that can buffer that effect of stress, and they can be physiologic, such as making sure to optimize all of the really simple things that we all know about: eating well, exercising, having good sleep hygiene, having good connections with social networks. But there's also a number of psychological things that can be taught, for example, to children as they're going through primary school and high school, that can help them better interpret or more effectively interpret negative stimuli in the environment, that can in turn have physiologic consequences on how they perceive and then feel stress. And over time that can also be protective.
Any comments, Phil?
So the question is, how do we prevent depression?
Yeah, is it possible, or?
Yeah, I think I agree with everything that's been said. I think my 2 cents is, if we could eliminate inequality, reduce child abuse, that would be 2 good things that would significantly reduce the prevalence of depression. From my point of view, that's what I hear a lot in my clinic.
So how do antidepressants increase neurogenesis? I suppose we go to you again here, Dhanisha.
Yes, so in fact, our own research has shown that certain classes of antidepressants act directly on the neural stem cells or precursors which are present within these neurogenic niches, thereby stimulating them and leading to increased production. However, there are also reports suggesting that some of the antidepressants increase the survival capacity of these newborn neurons. So there is both an element of increased production and increased survival of these neurons. That's the way probably the antidepressants actually contribute to increased neurogenesis.
Fantastic. Okay, I think this is a question for Sue. How do you define treatment-resistant or refractories in your talk before? Like, what stages does someone have to go through before they're classed as, treatment-resistant?
Sure, I think, and Phil can probably clarify this as well. The definition of treatment-resistant depression is somebody who's failed 2 antidepressant trials of adequate dose or duration, and that is essentially the limits of that clinical classification. But in reality, I would say that there's a spectrum of treatment resistance, and that doesn't take into account whether somebody has trialed 2 different classes of antidepressants, or it doesn't have any selectivity to that particular definition, which I think is something that needs to change as we better understand how different people respond more effectively on different treatments. Just because somebody's non-responsive to serotonergic or noradrenergic treatments doesn't necessarily mean they won't respond to something that might target a different system, the dopaminergic system, or an inflammatory mechanism. And I think that label can actually have negative connotations if that's not understood or explained effectively.
There's a question that scrolled through earlier.
Comment on that?
Oh, yes.
Yeah, so I guess from a clinical perspective, the sort of algorithm I follow when I'm seeing patients who who've come to me with quote-unquote treatment-resistant depression, I think you've got to ask a number of things. Number one, is the diagnosis right? Do they have a depressive disorder, or do they have complex trauma? Do they have a personality disorder? Do they have an incipient neurodegenerative disease? Lots of things can look like depression that aren't depression. Do they have a substance abuse problem? Are they taking the medication? Are they taking it correctly? Is the dose right? Are there cultural or social factors that have been overlooked in their presentation that are contributing to the maintenance of their depressive symptoms? So it can be a little bit complex, but then there is an defined algorithms that you would follow from a biological and psychological standpoint. So not just what drugs have they been on, what psychological treatments have they been offered. Is a psychotherapeutic treatment more appropriate for this person than a pharmacological treatment? And if it's a pharmacological treatment, then going through all the different neurotransmitters and augmenting with other therapies such as stimulant medication, atypical antipsychotics, transcranial magnetic stimulation, those kind of things. That's what we do.
Oh, thank you. So basically a lot of young people are presenting with depression now, potentially more than a decade ago. Do you have any thoughts as to why that's the case? Is it better detection? Is it maybe more things going on, or less resilience training in childhood? Or
no, a lot of people say, "Oh, depression is being overdiagnosed." I would flip that question. I would say actually the risk is that depression is being still underdiagnosed, because we know that suicide is one of the leading causes of death in young Australians, and just today, an AFLW player is thought to have died by suicide, and so we've got to ask ourselves: are enough people being diagnosed and treated appropriately for depression, given that it's a potentially fatal illness?
Yeah, thank you. Okay, so with stress responses having immune modulating effects in the periphery, is there a microglial effect essentially and does this have effects on development of depressive illnesses? So, Sue or Sue?
Yeah, and the question is yes, absolutely. And I think there's a lot of unknown sort of factors here as to what's the direction, or is it happening simultaneously? And that's a very active area of investigation currently. But microglia play a critical role in regulating brain function, as well as synaptic plasticity. And chronic stress in animal models induces a depressive-like phenotype through inflammation. And if you give anti-inflammatories early in that course of stress exposure, it can actually block that particular phenotype. However, later in the course, following that chronic exposure and the consequences on the immune system, actually stimulating inflammation is protective and has an antidepressant effect. So it's a very nuanced system that we really don't understand well enough at this point in time. But there are definitely strong links between the stress system, the inflammatory system, and the metabolic system, and they're all intertwined. So when one shifts, the other two also shift, and that there's still so many questions that we need answers for with respect to that.
Do you have any comments, Dhanisha?
Yeah, no, I completely agree with Sue.
We have a question from the audience now. So if you're speaking to the microphone, please.
All right, thank you. Thanks for the good presentations. So I just had a question about how we know that depression can exist concurrently with other medical diseases, and we also know that certain medications can induce depressive-like symptoms. Do you have different approaches to treatment for these sort of comorbidities, and do they pose their own challenges?
Yes, I guess I'm a liaison psychiatrist by training, which means that I'm a psychiatrist that works in a general medical and surgical hospital. So my day is spent meeting people with medical and surgical issues and depression. So I see a lot of people with depression in the setting of cancer, neurodegenerative disease, treatments that can induce depression. I think, one of the things you do as a psychiatrist is that you're trained to do anyway, is to formulate each case individually. So you've got to ask yourself, why is this person presenting with this problem, and why is this person presenting now? So you develop an individualised conception of each case, and that guides your treatment. So it's difficult to be sort of generally prescriptive, but for example, I'll give you an example. I treat a lot of people with Parkinson's disease, and what we see in Parkinson's disease, in the early stages of Parkinson's disease, is a very high prevalence of depression, primarily due to dopaminergic denervation. So as the dopaminergic connections in the brain are dying off, the brain becomes depleted in dopamine. Not only does that cause tremor, stiffness, slowness, but it can also precipitate anxiety and depression, because those fronto-subcortical circuits in the brain are not firing properly. So interestingly, what I do in those situations is I don't actually treat them with antidepressants. I say, look, you need to crank up your dopaminergic therapy. So I usually put them on a dopamine agonist, which is quite a powerful antidepressant in these individuals. So it does change your treatment paradigm for those people, yeah.
I might follow that question up. So how do you go about looking at that in animal models? Obviously that makes it a world more complex. Could you both answer? I don't know who goes first. But.
That is interesting in terms of, I think, not with respect to the example that Phil gave, but I think I can think of other conditions such as, for example, Crohn's disease or irritable bowel syndrome, where the frontline therapy there is actually glucocorticoids, the stress hormones, to manage the inflammation associated with those disorders. But as a consequence of that, there is a high rate of, or high incidence of anxiety and depression that develop in these patients. So I think studies have just begun to model these nuances and aspects of, in a way, two-hit models, where you have peripheral conditions like such as IBD, where you can actually model stress response and look at basically how that affects the changes in some of the stress axis, but also in the brain, and lead to some of the behavioral consequences. So I think these kind of more complex interactive studies in animal models have actually just begun.
Sue?
Yeah, and I would second that. And I think it really speaks to better understanding the physiology as a whole, because the different perturbations on physiology have different effects on the brain. So with inflammation, chronic inflammation, it can induce a depression-like phenotype through very similar mechanisms to Parkinson's in terms of the dopamine depletion, and drugs that are effective in Parkinson's can have antidepressant effects in those models as well, and even in human subjects in small trials. They've shown that that's similarly effective. With the metabolic disturbances, we see diabetic treatments as having very robust effects on that antidepressant-like response. So metformin is actually more effective than a serotonergic treatment. And I think partly in those instances it's about bringing things back into balance and facilitating where that specific deficit is showing up in the neurobiology.
It gets ever more complex. So there's a question that came through earlier that I'm actually interested in hearing your response to, Phil. So is DBS a cure for depression, or is it a temporary alleviation? Like, how effective is it in your hands, do you think? Well, not in your hands, but you know.
So I think I've seen that question. So is it the one that says DBS, is it just treating the symptoms, or is it?
Yeah, is it relieving the symptoms?
Yeah, I love that question. I get this question all the time with all treatments. So one thing some people say about treatments in psychiatry is that they don't treat the underlying cause, they just mask the symptoms. And that's a sort of statement that I try and counter, because whilst in psychiatry we can think about things from a molecular level to a historical and sociocultural level, what we've got with someone with very severe depression is a potentially fatal life-limiting illness with impacts not just on their well-being, but also depression is robustly linked to later medical ill health as well. So we've really got to treat it. And if just relieving symptoms helps people stay alive and reduces their suffering and allows them to engage with their families and raise their children and stay in their job, well, that's just fantastic, and I'm delighted by that. The other thing I'd say is that often when people are extremely depressed, even if you can formulate their case and say, well, this is the cause of your depression, the cause of your depression is that you had a bad, you had adverse childhood experiences and this trauma and these social and historical and cultural factors. Well, that's good, but how's it going to help the person right now to recover when they can't get out of bed, when they can't feed themselves, when they can't enjoy anything, when they're having suicidal thoughts, when they're hearing voices telling them that it's not worth living. So what these treatments do in psychiatry is they help the person recover to a stage where they can address those factors. So what I say to my patients is, well, this tablet, this pill, this therapy, it's not going to change your personality. It's just going to give you a leg up so that you can actually address all these other factors in your life and recover.
Excellent. So I think this will be the final question for today's discussion, but it's kind of a broad one, so you can all kind of touch on it. It relates to the time frame of these type of projects and experiences in science and getting to an endpoint, all right? And I think a lot of people have very short-sighted views of how quick these things progress, especially at the different levels that you're all doing research at. So would you comment on sort of how long it takes to get to these places where you might think of developing the next treatment, or to learn these processes and move the science forward, and in what ways you kind of contribute to that? So go from left to right. Dhanisha? My left to right.
Yes. As we know, discovery science to actually translating those understanding to from bench to the bedside, it is a long process. And I don't think there is a particular time frame that one can assign to such processes. I think it's far more important to concentrate on how we can push our boundaries towards understanding some of the intricacies of these processes, from molecular to cellular to circuit to systemic levels involving the whole physiology. But having said that, I think the current advances in technologies that we have at our disposal in neuroscience have, I think, already begun to make some differences. For example, there was a study published about, I think, 2 years ago, talking about how we can stratify or parcellate different patients suffering from depression into different categories based on their fMRI signature, and how that correlates with their behavioral symptoms, and which signature is actually responsive to TMS treatment, for example. And I think these kind of approaches will certainly have a way forward in our treatment options. So I think the process has already begun, but it's very hard to put a definite time frame on this.
Sue?
Sure, and I agree with everything Dhanisha just said, and I'd really just add that it's important to remember that translation from bench to bedside is very much a team sport, and the more conversations we have like this and the more interdisciplinary our research programs and clinical programs can become, and we find a common language across groups, then the faster this translational process will be. And I think it is speeding up. Progress is happening faster and faster because of that. And it's really part of the vision, I think, here for QBI, and medical research is really taking this in its stride, that it is team science, it's basic science, working hand in hand with clinical application and bridging every sort of aspect in between. And a big part of that is actually patient involvement and stakeholder involvement. So participating in the research, asking questions, making suggestions, all of that is really valuable and part of that team approach.
I agree with everything that's been said, 100%. It's fantastic, especially the collaborative element. I think as a clinician researcher, I'm at the bedside, but I can't do anything without the years of preclinical research that's been carried out. We are just so dependent on all of that hard work that's gone in before us. And the other thing, a couple of other things I'd say is that I think probably in psychiatry we've not made as much progress as we like, primarily because psychiatry is very difficult, and one of the things that we have been focusing on in the past is very broad diagnoses, and now I think we're focusing more on behavioural what we call endophenotypes, so subsyndromal patterns of behaviour that are perhaps transdiagnostic rather than unique to one particular disorder, which has a more discrete mapping onto what's actually happening in the brain. So I think that's a big progress for psychiatry, and we're seeing more and more research focusing on those kind of aspects now. And so I think progress will pick up, actually. I'm quite optimistic.
Good to hear. Well, thank you for the great discussion. I think my take-home message from today has been that mental health research needs to move more to where cardiovascular and cancer research is at. We obviously need to have better mechanisms to predict who's at risk and who might have these mental illnesses later in life, and also have a better way of personalising the treatment to each individual that comes through based on their symptoms, their brain patterns, and everything else. But it's heartening to see that such good work is going on, and I'm sure it's going to get to that at some point. So I'd like to thank the speakers for their discussion and insight into their depression research today, and thank everyone who's come and is online in the web. And I will remind everyone that you can re-watch the webinar by going back through the same link that the live webinar was hosted through. So thank you for joining us today.